associated with these things in specifically because it's a vesiculitis. So that's all of the blood vessels and stuff out there. After this, then I'm going to go through a lecture that is just about biopsy, surgery, sutures, all of that kind of stuff. So it's just some fun stuff. So let's get into these things, okay? So definition and classifications of these vesiculitis stuff. So heterogeneous group of systemic disorders, all characterized by inflammatory destruction of blood vessels. So things are happening that are either hurting our arteries, our veins. It's those things of the caps that is causing these things to occur. Inflamed blood vessels are liable to include or rupture or develop a thrombus. Okay, so we're going to get into some of these things and we're going to break them down individually. Degree of clinical manifestations highly variable based on the vessels and organ involved. So what is it flowing through that is causing this to happen? We've got primary, we've got secondary. Primary, most common classification is by size of the blood vessel involvement. So it's large, medium, or small. Okay, it's in regards to the vessel size that is out there. Secondary vasculitis is broken down into those ones. So rheumatoid arthritis vesiculitis, SLE associated vasculitis. So we talked about some of those things when we did SLE, and inflammatory bowel disease associated. So those are secondary. It's because they have that the comorbidity that is causing this to develop and present itself. Epidemiology-wise, 1 in 2,000 adults have some form of vesiculitis. 1 in 7,000 develops vesiculitis annually. Most common form of primary vasculitis. So primary, it's not associated with that other stuff. It's in and of itself. It's depending on that size of that vessel. So GCA, we are going to talk a lot about that. We're also going to talk about granulomatosis with polyangiitis, formerly Wegener granulomatosis, microscopic polyangiitis. Those are things out there, okay? Challenging is the diagnosis. It's not easy to actually put these things out there. Considerations for classification besides the blood vessel. Okay, so what is the individual? What is the patient? Age, gender, ethnicity. Those things will be pushed into those directions. Pattern of organ involvement, specific pathology, immunocomplex deposition, granulomatous inflammation. Okay, what are those labs that are out there? What are those other infections that are associated to it, i.e. Hep B or C? So let's talk about it now. So large vessels, Takayasu's arteritis, giant cell temporal arteritis, GCA, polymyalgia rheumatica, Behçet disease, T-cell mediated antigen-driven pathophysiology. Okay, so those are the ones that are in that classification of a large vesicle. Medium, we got polyarteritis nodosa. We've got thromboangiitis obliterans, so Buerger's disease, and Kawasaki disease. Y'all remember that strawberry tongue? Okay. Small vessels, so we can get to that immune complex mediated vesiculitis. So cutaneous vesiculitis, Henoch-Schwann purpura, cryoglobulinemia. Then we've got ANCA-associated vasculitides, so those are broken into granulomatosis with polyangiitis, eosinophilic granulocytosis. God, this is like talking so much. With polyangiitis and microscopic polyangiitis. So those are some of those ones that are associated, whether it is small, medium, or large. We're going to spend a lot of time talking about the large stuff. Etiology is generally unknown for nearly all types of vesiculitis. Why is it there? We don't know. With probable factorial causation. So it could be some other thing that is happening. Immune-mediated factors, right? So antibody associated because of that immune system activation. So granulomatous inflammation, immune complex deposition, genetics, ethnicity, Behçets, Turkey, we talk about Japan, Kawasaki. Environmental factors that could be out there, smoking, thromboangiitis, obliterus. Talked about infectious stuff, hepatitis, B or C, cryoglobulinemia, polyarthritis nodosa. So with these clinical features, when to consider the diagnosis, multi-system disease. What is your medical history? What are you on medication-wise right now? What is this for? What is that for? We're getting all of that soap note information. Constitutional symptoms, are they, upon presentation, are they feverish, malaise, sweats, fatigue, loss of appetite, weight loss? Atypical ischemic signs and symptoms, so young patients, extremely ischemia. What is the hemorrhage looking like? Are we having some type of a petechiae, purpura, ecchymosis? So these are the things that we want to be looking into as we're thinking about that. So now we're going to talk about some specific ones associated with the vesiculitis, okay? First up, we're going to talk about levato reticularis. So this is reddish, purplish, reticular pattern of the skin. What's something similar to a reticular gland that we talked about in block 2? Wickham's, right? It's got that reticular, like it's polygonal, like it looks like that pattern that is out there. So that's that reticular pattern. Can precede ulcer formation, swollen venules from obstruction of the capillaries. So that's a picture of it. See it over there? We see that. Looks like that's at the bottom of the legs, huh? So it's down there. Tib, fib, ankles. That could be where we're seeing these things at. Another one, palpable purpura. So we know when we've got that purpura, it's spread out. It's not just like petechiae, it's petechiae that's larger. So that's that palpable purpura. Again, lower extremities area. Next one, mononeuritis multiplex, aka foot drop or wrist drop. Damage to either the sciatica or the perineal nerve area. So that's infarction of that radial nerve or of those things out there that help to move those things out. Again, it's not getting in so much of a description of it, it's just showing you what they look like. But one of them, we're going to talk about it a lot and get a lot of information. So this one is a key component, big one. GCA, giant cell temporal arteritis. I know that y'all have spoken about these things in previous courses that you took. But now here's some highlights for it in the Derm room aspect. So epidemiology, most common type of vesiculitis in adults. Most common, 1 in 500 in people over age 50. Again, age greater than 50. Female predominance, 2 to 3 to 1. Preferentially affects the external branches of the carotid artery. So y'all, even when y'all were in y'all's freshman semester, y'all were learning how to do of the palpation of the scalp and all that kind of stuff, where this artery is at, and you should not want to feel it at all. But if you did, then no bueno. 50% of GCA patients also have polymyalgia, so multiple muscle pain, myalgia, rheumatica, yeah. Aching, and stiffness of the shoulders, neck, and hip girdle area. So that's what PMR is. So 50% of the GCA will also have that same aching and stiffness. So classical presentation. Good slide right here. Individuals will start to have a new headache. They'll have jaw claudication, most specific. So if they chew, so if they try to clench their teeth, then they get that pain. They have that scalp tenderness, which we just talked about. You're going to be trying to feel for that temporal artery, then you could feel that on that scalp. Visual symptoms, okay? Is this a patient having some blindness? Are they having some difficulty seeing out of one of their eyes? Polymyalgia rheumatica, we just talked about that. That is of that neck and the shoulders and the hip and, you know, those areas. Y'all know Mr. Souffle doesn't like labs at all because I'm not a lab nerd, but a big one that I like a lot is ECR. ESR, very high, oftentimes very, very high. And you'll see on this next chart, we'll see some of that classification criteria. 90% of individuals who are having GCA has an ECR that is through the roof, okay? Greater than 50. As stated there. So on this chart, we're talking about the age, we're talking about the new headache, we're talking about that temporal artery, we're talking about abnormal artery biopsy. But you can see there, an ESR greater or equal than 50 millimeters hour is part of the criteria. So ESR. Again, yes, talked about that. Needs to be done within 2 weeks of steroids before biopsy. Results will be altered. Consider second biopsy if clinical suspicion is high after initial negative biopsy. So let's talk treatment-wise. Okay? Treatment-wise for GCA, which y'all will be seeing this, I promise you, because he walks into our ERs quite often. Goals to reduce risk of vision loss. So prompt initiation of high-dose corticosteroids. Okay? Patients with suspected GCS who have experienced transient visual loss for a few hours should be admitted and given high-dose IV prednisone. So they are going to be admitted if they're having vision loss. If they're coming in here presenting to you, right, they've got that the vision abnormality, if they're having some of that jaw pain, if you can palpate that temporal artery, if they could be having some other constitutional symptoms, but the key component is visual loss, then we're going to admit them and we need to get them on some IV prednisone. Once we do all of that, then of course we're going to send them home with some oral prednisone. If there's no vision loss, then we're automatically going to just jump in the prednisone. But if that vision altercation is there, then boom, da da boom, da da boom, boom, boom. Most of these individuals, if they've got GCA, they'll have to have that treatment last for about a year. So, prednisone. After the first month of treatment, almost all patients will have normal ESR. So it'll drop down below to 50. And then we can start to taper down some of those steroids. We can also consider some addition of a low dose of aspirin, right? So let's thin out that blood a little bit so that we don't have this happen again. Okay? Do not delay steroid therapy while awaiting temporal artery biopsy. We're going to push that right away. Last bullet, ignore it, because it does state that sometimes if they can't use GCA, then they'll get into those biologicals, so they'll get into something like methotrexate, but that is not the key component. It's controversial. Prednisone it is. Medium vessels, so now we're talking about medium ones. This chart right here breaks them down and to show what they are, right? So necrotizing arthritis without MCLN syndrome, so polyarthritis nodosa, that is that. What does that look like? Well, it's that, okay? Looks similar to those same things, but this is more of a medium vessel that is out there. So with PAN, that necrotizing inflammatory vesiculitis of medium arteries and muscular arterioles spares venous circulation and capillaries, so it's confined to that arterial circulation. Subacute constitutional symptoms, so they have some fever, weight loss, malaise, lower extremity nodules, mononeuritis multiplex, so that foot drop, and interstitial angina, so they get that postprandial pain. So after they eat, something is just not feeling like it's sitting well. Angiogram or biopsy of involved organ required for diagnosis. So what organ is acting up with this blood flow that is causing this to happen? Epidemiology. Basically, that is other types of vesiculotides. This is very rare. Ratio is even with both male and female. Key component with PAN, this could be associated with Hep B or Hep C. PAN, B or C. PAN, B or C. Treatment and vaccination of Hep B is reducing incidence further. Usually an insidious onset of constitutional complaints, so fever, weight loss, arthralgia over weeks to months. Again, Hep B is on there again, talking about occurs with 6 months of infection. So they had the Hep B, and for 6 months, and then they start to have this PAN. Peripheral neuropathy, so weakness. Mononeuritis multiplex, so they get that foot or that wrist drop. So they can't hold it up because they got that radial nerve or those other nerves that are acting up. Sciatic. Abdominal pain may be prominent depending on mesenteric vessel involvement. Again, intestinal angina, so that eating stuff. These do not look good, okay? So you'll see that. Clinical characteristics, secondary hypertension from renal artery involvement, dermatological findings, so they'll have that palpable purpura, levita reticularis, skin ulcers, digital gangrene, pulmonary involvement absent. So their lungs are good. Laboratory, Hep B testing, biopsy, skin, affected nerves, muscles, characteristic transmural necrosis, so they've got that stuff. Angiography for that mesenteric to know how many microaneurysms could be added to this. PAN treatment, we use prolonged high-dose corticosteroids. However, if those things aren't working, then we can jump into cyclophosphamide for patients whose disease is refractory to glucocorticoids. So PAN, B, cyclo. Prognosis is poor without any type of a treatment. They have a 10% 5-year survival rate. Advanced mononeuritis multiplex can be severely disabled, problem from the recuperation of the measured of months or years. Again, we treat those comorbidities that were out there that need to be treated for that. So that was a morning of rheumatoid room stuff. Okay? The last one, the last lecture of this entire course is going to be us talking about some of the fun stuff we are going to do once we get into Derm and Surge lab, once y'all are poking and sticking, stabbing each other, when we're going to ATM and you're going to be doing some stuff. So these are things that we are going to be looking at. So, biopsy and suture techniques. This is basically just pointing out some of the things that y'all are going to do, not only here, but once y'all get into phase 2, you're going to be doing shaves, excisions, biopsies, all that kind of stuff with derm, surgery, back and forth. So y'all are going to become pros on this stuff out there. Again, when we do that derm lab, we will have some of the pig feet, and so y'all will learn how to do all of the sutures and things out there, whether it's of a horizontal mattress, if it's, you know, solitary, if it's this or that. We're going to go through those things, and I'm going to let our surgical and EMed folks teach it more than me. I'll just run around and stab with y'all. So, excisional or incisional, okay? Only portion of the tumor is removed, but excisional is the entire tumor is removed, plus some of those normal skin cells and other things like that, okay? Y'all know excisional is what we want when it comes to derm and all of the block 3 cancerous things that we did. Excisional. Again, showing it there. Get it all. Well, how do we do biopsies? Well, we can do that a shave biopsy, so it's like you got a razor and you're scraping it away to get it out. We can punch at it, so that's basically that diameter of that punch is larger than the lesion in and of itself, so you're taking all of that out of it there. But then excisional, that's us cutting up and under to get that stuff out. We use anesthesia sometimes if these things are large or if they're in a location that can cause a significant amount of bleeding. We use lidocaine, bupivacaine. As I said, with that bleeding areas, we can use that epinephrine with the vasoconstriction. So those locations that we can use that more. Once we do that, we let it soak it in. Lidocaine has a rapid onset, so that'll get in there for 2 minutes and it'll last 1 to 2 hours. Marcaine, it takes a little bit of a longer time, but it lasts even longer. So 5 minutes and duration 4 to 8 hours is how long that one is there. So that's that. Instrument-wise, we've got scalpels, right? So we've got 10 blade, 11 blade, 15 blade. There's a lot of those things out there, but you will become familiar with the ones that work the best for you. We can have something that is already sent to you with the blad attached to that plastic scalp, but if not, then you can hook them up. So there's some of those other pictures of the things out there that you would see. There you go. If we're going to shave it, it's like a razor blade. So we're pinching it, raising it up a little bit, and then scraping it up and under like we're mowing the grass. So that's what that is called. We always have these needle holders that we can use. Again, I'm not testing you on sizes and all of these things, yada yada. Okay, this is just pointing it out to y'all. These are just beautiful pictures of the forceps. So that's that pinch that can help to lift up the skin, move stuff out of the way. That's what we use. We got hooks. Again, moving skin and stuff out of the way so that we can then use that other stuff out there. Talked about shave, okay? To obtain tissue for diagnostic purposes. To remove benign surface neoplasms, so SKs, warts, benign appearing nevi. That's what we do some of the shave for. For raised lesions, when full thickness tissue specimen is not necessary, then we can use the shave biopsy. But if we think that this is malignant, then we're going to excise and not shave, because we would want to get everything. Techniques: mark the lesion prior to anesthesia, insert the needle into the dermis, and puff it up. Raise a wheel, so it's pushing up that lesion so that it's a little bit easier for you to shave through that there. We could be using a number 15 blade, a Derma blade, which is what we just saw, that razor, or a Gillette. Non-dominant hand to counter traction and stabilize, right? So if I'm a right hand, I'm going to shave with the right hand. I'll use my left to lift it up, push it out or in or up or around, up and down. Shave contraindications. Why we do not want to shave? Well, if we think it's malignant melanoma, then we're definitely not going to. Shave does not give full thickness of a tissue specimen, so that's the reason why we want to completely excise that. So we need that full thickness and degree of invasiveness. Advantages: it happens quick. You don't need any sutures because you're just shaving them. Assistant not necessarily needed. Clean the procedure, localization of the site, wound care simple, no restrictions. So these are those things out there. That's advantages. Disadvantages: well, it can cause some hypopigmentation. You could cause them to have a scar. You could do a deep scar, or you're not getting a full thickness of a diagnosis. Okay. Again, showing some of these things that could be happening, like we just did with those disadvantages: scar, hyperpigmentation, erythema, regrowth, infection, da 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 da. So there's those steps, right? So we're going to put that we're going to put that lidocaine up and underneath of that kind of stuff, raise it up a little bit, lift it up with those the forceps, and then shave it down, cutting through it. Not only could we shave, but we could snip. We got some wonderful scissors. So if it is a peduncular lesions, it's termed as a shave biopsy, but it's a snip, snip, snippy. Punch, full thickness. Most superficial inflammatory and bullous diseases, okay, benign and malignant, except for malignant melanoma, like, right, we don't want to use punch biopsy on those things. The sizes range from 2 to 8, and that just specifically states what the diameter of that hole is. So what's the size of the lesion will determine what we do when it recovers to picking that order. Punch techniques: just like before, we're going to be using that lidocaine, marthacaine. We will inflate, raise it up, wait for the time that we needed, and then go ahead and punch. And it's almost like you're twisting up until it pops, because now you're into that sub-Q area, so it pops in there once it gets into those fat cells. Then you know you've gone all the way through epidermal and of the dermal region. So you'll feel that pop as you're going in. Then we're going to raise it up, snip it, cut it, shave it. More pictures again. You can see where they had already marked it. That helped them to determine the size of the punch that they're going to use. Then they pop it and get it out. Contraindications. Locations. Use caution if it's in an area where the arteries or the nerves are. If you punch all the way down into that, then you're going to get nerve damage or you're going to get death by blood. I don't know. It depends on which artery you're going to hit. So, yeah. Advantages, you get that full thickness because it's all the way into the sub-Q. Better cosmesis, faster healing, easy to use, relatively inexpensive. Bad stuff, hypertrophic scar. These things do use some of the suture. So if you use sutures and they begin to have some type of a infectious process or some other things, then they would have to come back to see you, or if they have to have it redone, they would have to come see you. So there's those same complications out there. Redness, scar, bleeding, infection. We're going to punch and then we're going to get it out. So the big one, the one that we use more than common just because of the fact that we want to get that full thickness because we have some concern, then we do excisional biopsy. So it's a deep inflammatory disease, so erythema nodosum, malignant melanoma, deeper nodule lesions, so BCC, SCC, we're doing these things that are going to push us into excisional biopsy. Preoperative evaluation, okay, allergies to medications. Are they on any of NSAIDs or aspirins or anticoagulants? Because we don't want them to bleed out. Use of alcohol, tobacco, HIV, hepatitis. Tendencies toward abdomen wound healing. So keloid, hypertrophic scarring. We know that if it happened somewhere else, it can happen in this one again. So that's one of the things for us to look into. Determine relaxed skin tension lines or natural wrinkle lines of the skin. So place incision to parallel or fit with these lines. Of course, we know that we want to take a widespread, or not widespread, but we want the cut to be more than just what the lesion is. So usually that is 2 millimeters of margin of the normal skin. So we're taking the good skin out with it. Draw ellipse with surgical marking pen. Length should be 3 times in the width, longer is okay. Ends the ellipse 30 degrees to avoid dog ears, which you'll see a dog ear is seen in the pictures below. So those are those wrong ones. You've crossed over, you've made those dog ears. You can see that what they're showing you is how we're making it look like a football. Okay, so we want to come up and over and then up and over. 2 millimeters, cutting that out, just like that. You see that lesion, you can see those borders that are well seen, so we know that all of that excision has been cut out. Dun, dun, dun. Techniques, local anesthesia. Yeah. Traction with opposing hand, use the belly of the bell, depth of incision. So we want to go all the way down to that sub-Q fat. We're going to use those forceps and snip with scissors or scalpel blade just to get that out. When we're going to closure, we need 1 to 2 layers of suture. If using 2, then we have to consider some of those things. What does that mean? Well, that depends on the size of the excision. whether this is surgical or even if this is you're in the ER and some dude is brought in because he got in a drunk fight and got stabbed and has a laceration all over here. You can get in there and see all of his damn stomach and all that, so it's deep. Well, it's not just going to be of a superficial suture, because you're going to have to go down deep first and then close it over the top. And we're going to look at a chart. It's one of our last slides, and y'all are going to remember that, because I might ask you which sutures you want to use. Again, first layer, that's that subcutaneous area. So this is us getting into that space to put that absorbable suture material. So we're going to leave it in there. So we're using that absorbable suture stuff to just put those things back together. But then we're going on that second layer that's up at that top, so of the epidermal stuff. So that's that non-absorbable stuff. And we will then see them back, make sure that they're not having any infection, and that we can heal it up. Complications, of course, scar, wound infection, excessive bleeding, nerve damage. Those are all things that are out there. We've got closures that we're going to show you some of the pictures of those things at. So you have a simple interrupted. So oftentimes that is the one. That was what you saw on that very first picture of the slide deck. That's just to put one, close it, put another, close it, put it, close, not wrapping it around or going in and out and up and down. It's just back and forth. Sub-Q, that's that stuff which we're going to be seeing right here. Again, deep goes first, and then we're going to do that superficial epidermal area after. There's also something called running. Okay, so this is that horizontal mattress, vertical mattress. These are those there. So that is that mattress. So you can see how it starts up, goes up, and it goes down and below, then it crosses over below, and then it comes up. Yeah, it's like running a mattress party. Ah, it's fun. Post-operative wound care. To prevent contamination, we want to have them getting into some of that medications. Contributes to the healing process and partially immobilizing the wound. Best results, keep moist and covered, avoid sunlight. Keep a bandage on for 24 hours. After bandage removal, cleanse the wound with soap and water. Apply topical antibacterial ointment. So the Bactroban or something out there. Do not expose the wound to the pools, the hot tubs, the salt water. Yeah, it's a lot of stuff in this slide deck that I didn't write this one. Okay? It was our surgical people. Patient wound care sheet. Tylenol is safe. Avoid aspirin, ibuprofen, alcohol. So those things that'll thin our blood. We want to avoid those things. If bleeding occurs, apply firm pressure with your hand over the dressing. Keep the pressure for 20 minutes and da-da-da-da-da-da. Okay. Patient wound care sheet. Infections do not occur. If you're having increasing pain, like this is written for a patient. Please return as requested. Warn physical activity patients from the activity. Blah, 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 blah. All right. So here you go. I talked about a suture choice chart, and this is it. Because on here first, we're talking about the location. Where did this injury, this trauma, this laceration, where did it happen? Because those are different components to what we would be using because of vascular and other things like that. That will tell us what the size, what is that material going to be, okay? Is it deep? Then yes, I'm going to be using this one, but I'm also going to be using this one as well. If it's only superficial, then I don't have to think about deep stuff, so I would pick over here. So Let's say if there's a laceration that has happened and it's been on an individual's trunk. All right, well, if it says that it's deep, then I'm going to pick 2 to 3 Vicryl and 3 to 4 nylon. Okay? So, I will ask you a question. I will give you a scenario. I will give you that, and you will know, is this deep? Is it superficial? Where is it at? And what am I going to pick? What am I going to use? Okay? All right. See, I already told you what one of the test answers is. Because I just said it. So that's that single. You could have sutures, staples, I mean. Sorry, I didn't mean that. Staples. So that's what it looks like before and after. Simple interrupted. A horizontal mattress. So it's just pulling those together. So that's what it looks like in live. And that's a vertical mattress. Ladies and gentlemen, that is the end of dermatology course lectures for y'all. Do we have any questions?